Welcome to this medicine masterclass in which we will be discussing lung cancer. Let's think about the way lung cancer can present. Patients can present either with symptoms related to the cancer itself, subsequent compressive symptoms, symptoms related to metastasis, or paraneoplastic symptoms. The cancer itself can cause a cough, shortness of breath, hemoptysis, weight loss, night sweats, fever, anorexia, and fatigue. Compression symptoms, mediastinal involvement may result in hoarseness of voice with left-sided lesions due to compression of the left recurrent laryngeal nerve. SVC obstruction with right-sided tumours may result in Pemberton sign, morning facial swelling, venous distension of the neck, made worse by raising the arms above the head. Elevation of the hemidiaphragm may come about from phrenic nerve paralysis, and dysphagia from esophageal obstruction and pericardial tamponade. Metastatic symptoms will depend on the site. If the metastatic deposit is in the brain, the first presentation or manifestation may be a seizure or confusion. If it's an abdominal metastasis, may result in abdominal pain. And usually the initial presentation with a metastatic focus is from adenocarcinomas. Paraneoplastic symptoms could be pain in the arms or legs caused by hypertrophic pulmonary osteoarthropathy. This is a reaction of the lung bones to the tumour. Hypercalcemic symptoms from squamous cell cancers, or neurological syndromes. Examination, there are key things to look for. In the hands and wrists, observe for cachexia, intrinsic muscle wasting, clubbing, tar-staping, and hypertrophic pulmonary osteoarthropathy. In the face and neck, look for Horner syndrome. That would include signs such as ptosis, meiosis, ipsilateral anhidrosis, and anophthalmos. Cervical and supraclavicular lymph nodes, and distended neck veins. On the thorax, inspect for radiation tattoos, signs of consolidation, collapse, or pleural effusions, previous pleural drain scars from recurrent effusions as a result of the cancer. Look for other scars, for example, an open thoracotomy scar for a biopsy or a VATS triangulated scar for a biopsy. Observe or examine for decreased chest expansion associated with collapse, dull percussion of the tumour, and a monophonic wheeze where the tumour is compressing the airways. The other signs on examination could include bone tenderness, hepatomegaly, and they may also have neuropathic signs, and the voice may appear hoarse. The investigations that are required for lung cancer: bloods looking for anemia, infection, hypercalcemia, and hyponatremia, which can be paraneoplastic manifestations. Sputum and pleural fluid cytology may give an indication of an underlying malignancy. The chest radiograph may demonstrate consolidation or masses, and a CT scan would provide more detailed imaging to define the mass. Bronchoscopy, high yield when the tumour is visualized directly. And when it's not visualized, a bronchiolar-alveolar lavage washout is performed, and cytological assessment can help with the diagnosis. Bone scans can be helpful in determining metastatic spread to the bones, and a PET scan is a very useful investigation to help stage the tumour. And of course, pulmonary function tests are needed to help manage the patient with respect to surgical interventions. Histologically, we broadly divide tumours as small cell and non-small cell. Small cell tumours account for about 20% of lung tumours, and non-small cell account for the remainder, circa 80%. Of the non-small cell cancers, patients can have squamous cell cancers, which are usually central tumours, adenocarcinomas, which are usually peripheral, large cell cancers, and rarely alveolar cell cancers. Small cell cancers result in several classic paraneoplastic syndromes. For example, SIADH secreting tumours can result in hyponatremia because the symptom of inappropriate antidiuretic hormone causes a retention of water, resulting in a dilutional hyponatremia. Small cell cancers can also secrete ACTH, resulting in excessive cortisol production, resulting in Cushingoid appearance. Eaton-Lambert syndrome, which is again mediated by small cell tumours, can cause the antibodies against the voltage-gated calcium channels, resulting in loss of power, which increases with repeated use and decreased reflexes. Carcinoid tumours, which can secrete 5-hydroxytryptamine, can manifest in flushing and diarrhea. Another important tumour is a Pancoast tumour, which is a non-small cell apical tumour and is defined primarily by its location, and this tumour can spread quite rapidly to the ribs, the vertebrae, and cause compression of the brachiocephalic vein, the subclavian artery, and the phrenic nerve, resulting in recurrent laryngeal nerve and vagus nerve palsies. The tumour can also compress the stellate ganglion, that's a ganglion belonging to the sympathetic chain, which results in Horner's syndrome. And Horner's syndrome, the patient would have ptosis, usually partial, anhidrosis, meiosis, and ophthalmos. And if you're thinking about congenital Horner's, they may also have heterochromia iridum, which is a difference in the colour of the irises. How do you manage patients with lung cancer? Of course, it's a multidisciplinary team approach, a patient-centred approach. The patient tumour needs to be staged. This helps identify candidates who are amenable to surgical resection, as that's what offers the highest potential cure if the cancer is found in a timely fashion. Surgery is beneficial in non-small cell cancers with adjuvant chemotherapy. It's limited in small cell cancer because 90% of them would have metastasized by the time of the diagnosis, and surgical options are either a full open surgery, a VATS procedure, lobectomy or pneumonectomy plus or minus lymphadenectomy, depending on the advanced nature of the disease. Small cell cancers respond very well to chemotherapy, particularly etoposide and cisplatin appears to have a very good effect, but of course each cell is staged and undergoes testing. In small cell cancer, like I mentioned, so many of the cancers metastasize that surgery is usually not an option. Radiotherapy can be administered for palliation, particularly when patients develop pain, breathlessness, dysphagia, hemoptysis, or SVC obstruction, and particularly useful for advanced Pancoast tumours or those with cerebral metastases. Small cell cancers respond well to chemotherapy. Etoposide and cisplatin appear to have good results, but each cancer is investigated in its own way. Surgery is limited due to the fast rate of metastases by the time of diagnosis. Radiotherapy is useful for palliation, particularly in patients with advanced pain, breathlessness, dysphagia, and hemoptysis, or when there's evidence of SVC obstruction. Pancoast tumours and cerebral metastases also respond to radiotherapy. Prognosis-wise, small cell cancer survival is very poor if untreated, a matter of months, and if treated, potentially 18 months. Non-small cell cancer survival is better if treated before metastases develop. Just a note on video-assisted thoracoscopic surgery. Now, this is very useful for lobectomies, apical pleurectomies, wedge resection for nodule resection, decortication, and bolectomies. And if a patient has a non-small cell cancer and you're able to resect it, they may undergo a lobectomy using this approach, or they may have an open approach. In order to manage non-small cell cancer, patients should have a good functional status, and in a patient who's had a lumpectomy, there may be no little clinical signs apart from the scar itself. If the patient's had a pneumonectomy, the trachea shifts towards the pneumonectomy and they have a dull percussion over that area. The criteria for surgical intervention is a good FEV1 of more than 1.5 litres, and for a pneumonectomy, they should be at least 2 litres. They should have a good transfer factor, no evidence of severe pulmonary hypertension, no evidence of metastases, and a good functional status. Patients who have a poor functional status, unlikely to be cured, are not put through such aggressive surgical management. Thank you for attending this medicine masterclass.